All right, everybody, we are back with another episode of our Daily Doc Talk. I had a comment on Instagram today that has kind of sparked this discussion, and it's the idea around treatment non-responders, which I'm obviously going to frame up in the interventional orthobiologic space, but it also applies to a lot of other interventions in the physical realm for chronic pain. So, set the scenario. You are given a diagnosis and you are then told that a treatment can be helpful for that, and you undergo that treatment. In this case, you've been given the diagnosis. Let's go with degenerative disc disease, and you've been told that an epidural, and we'll even say this is platelet-rich plasma, an epidural of platelet-rich plasma or another plasma-based product can be helpful for that. And you get that procedure. It's a little bright here. You get that procedure, and then you don't have a positive response, meaning you didn't get any better, okay? Another example that more people might be familiar with is you've got, let's say you've got back and leg pain. You've been told you have the degenerative disc disease with some stenosis, and then you get an epidural, and that epidural does not help any of your pain, and it's a steroid epidural, and it doesn't help your pain. So these are treatment failures. Now, there are many different reasons why treatments may fail, okay? Right off the bat, there are many different reasons. So what I'm going to discuss here is not the only reason that somebody might have a treatment failure. It's just a reason that I don't think gets enough discussion, okay? Because I think it happens more frequently than we acknowledge, than the medical field likes to admit, and it is misdiagnosis. Now, that doesn't mean that your original diagnosis is incorrect, meaning it's not that the radiologist who looked at your MRI was incorrect in saying that that was what they saw on imaging. It is not incorrect that the provider who did your workup, it's not that the diagnosis that they gave you is necessarily wrong, especially when we're talking about imaging diagnoses, because when you take an ultrasound, an MRI, an X-ray, a CT, any of that type of stuff, you're gonna get, more than likely, if you've got chronic pain, there's more than likely gonna be some changes that are seen there. Those are structural changes. Now here's where the problem is the structural changes are often then attributed to your chronic pain. Or I should say another way, your chronic pain is then attributed to those structural changes. And that may not always be the case. You may have degenerative disc disease, and that degenerative disc disease may not be causing you any pain whatsoever. You may have an annular tear, so a tear in the annulus fibrosus around your disc in the low back, and that may not be causing you any pain whatsoever. You may have a rotator cuff tear. You may have a tear in your supraspinatus tendon, and that may not be causing you any pain. I could go on and on and on and on with this. These structural changes found on imaging do not always cause your pain. Sometimes they do. A lot of the times they can. But it's the fact that a lot of places will make this assumption that if you have pain in the shoulder and you get an MRI and that shows that you have a rotator cuff tear, those must be exactly that. It must be. What else could it be? Here's the problem, is that unless you have done a proper physical assessment and workup to actually load and stress that supraspinatus tendon to see if it is painful under load, to see if your brain is actually perceiving pain from that supraspinatus tendon, you can't match up that structural diagnosis and your pain. You need that other piece of information, which is the brain perceiving that tissue as painful? So, that being said, when somebody comes in, whether this is from myself, they have had a non-response, or they come and they've had a non-response at a different clinic from different providers, when we are discussing our more interventional approaches, so our injections, surgery, those types of things, a lot of the times what I believe is the reason that those responses were not positive and not seen is because the previous healthcare team did not properly diagnose what tissues were causing pain. So again, it's not that the rotator cuff tear or the degenerative disc disease is not, it's not that it's not there, because it was there, it is found on imaging, but the missing link is that that's not what was actually causing that patient's pain. So if you've got the rotator cuff tear on imaging and you get a steroid injection into the rotator cuff, or you get a PRP injection into that supraspinatus tendon, and it doesn't help your pain, then one of the potential reasons is that that supraspinatus tendon was not causing you pain. And let that sink in again. That place might not have been causing you pain in the first place. Now, like I said, there are other potential reasons why somebody might fail. It could be the injection location was not technically accurate. So you go to put the injection in one place and it didn't actually get into that spot. That can sometimes happen with things like epidurals and whatnot. And so that's another potential reason. The health and comorbidities that a patient may have can make it really difficult to have a healing response. Obviously, if you have had a lot of steroid injections into an area and it wears off over time, it's not that the diagnosis is wrong, it's more so that you are desensitized to those steroid injections. So there are other reasons, but I just think that this misdiagnosis and mismatch is something that is not talked about a lot. So what do you do? You've had a procedure and you have not seen a big positive response. What do you do? Well, in my opinion, the best thing there to do is to step back and reevaluate the problem. Reevaluate why is the pain there. So if you're working with a provider and they do a procedure and it doesn't work, and they don't then step back to go, oh, maybe this diagnosis was incorrect, let's look at treating something else, or let's step back to the drawing board to re-diagnose, then I encourage you to maybe look into finding another provider who might be able to look at that with fresh eyes, okay? If your provider is able to step back and go, okay, it doesn't seem like this is the cause of your pain, let's move on to the next thing. So, okay, it doesn't seem like your discs are causing your pain. It might be your sacroiliac joint. Let's move on to that next and let's try treating that next. That's an appropriate thing to do, right? It's acknowledging that, okay, even though this was our original diagnosis, you didn't see a response. So that must not be, more than likely not, what's causing your pain. So let's look at a different structure or a different approach or a different paradigm or a different way to think about this problem. Sometimes you do need to step up in strength. So if you're doing, let's say, some dry needling in an area, let's say you've got diagnosis of supraspinatus tendinopathy, and you get dry needling into that tendon, and that's not really helping, then maybe you actually might need to step up to something stronger, because that therapy is not strong enough to stimulate a proper healing response in you. That's another possibility. Sometimes you have to step it down. You have to go back to the basics. You might not be healing because your body is not set up to have a really good, strong healing response. And so working on things like sleep, nutrition, hydration, exercise, social connections, all those things, movement and exercise that I talk about on a constant basis. So there's a lot of variables here. There is no one right answer. There's no algorithm to follow. This is an individualized process. So I'm trying to teach you guys the principles and how I think of this when a patient comes into my office, so that way you can hopefully help navigate this world when you do not see a response from an injection. So hope you're all having a great day. Thanks a lot.